family, it's Dr. Ariana here, and welcome to the Stage You See podcast. I am your host, and today I'm going to be talking to you about the Menopause Society Conference 2024 that was held in Chicago. That conference is one of my favorite conferences. It is all things women's health, and it's called the Menopause Society. And of course, we're dealing with everything menopause, but at the end of the day, it's really everything that's starting to happen to us as we go through this perimenopause transition and really into the rest of our lives. So I have about 4 takeaways. There are several things, and I'll mesh some of those in with the conversation. But what I wanted to do this episode is to really just break down some of the basic science around the menopause transition, especially as it relates to metabolic health. I'm going to be talking about some of the findings that we see with brain health and estrogen and its impact on the brain and how hot flashes impact the brain. We're going to be talking about anxiety and depression, when that shows up and some of the issues that come along with that, obviously. And then finally, bone health and muscle health. So 4 main topics. For starters, how you doing? You know, this podcast is obviously for me to give you information and keep you informed, but it's also for me to check in with you and to let you know that the changes that you might be experiencing are normal. You're very normal. This is all part of the master plan. And the more you can just be educated around how your body is changing, the better you can adjust to those changes. So I am pretty passionate about this because I went through perimenopause very unprepared. I had no idea until years in that I was going through perimenopause. And that was after everybody's heard the story. I was ready to kill my husband. I was ready to eat the kids. Yeah, it wasn't good. And it took a long time. Like I literally thought I was getting early Alzheimer's, the brain fog, the joint pain, the fatigue, the insomnia. So I'm just here to tell you first and foremost, you might be going through some changes and it's okay. There is help. And I'm here to educate you and hopefully help you not feel so isolated and not like feeling like you have control or that you're not in power. You are in power, and so many of the symptoms that we experience can be mitigated with simple changes, lifestyle changes, medications for real, because sometimes you just got to take the pill. This episode is going to be around those changes that I talked about, and I'll be referring to my notes, and Duke will be coming in and out as he likes to do because he thinks he runs the show, which he kind of does, but hey, here we are. So the first thing I'm going to deal with is some of these metabolic changes. I can't tell you how many women come in the office and at the end of the day, they're just like, hey, what's up with this belly fat? I have seen my belly just increase for no good reason. I am eating the same amount of food. I'm working out 5 days a week. Like what's given here? During this menopause transition, the metabolic changes that are very specific are going to be a reduction in the way you're able to metabolize glucose. Estrogen plays a significant role in how our hormones work and how we metabolize sugar and how we store fat. So as we go through this transition and our estrogen levels decline, our ability to have the same metabolism declines. And what's happening? Specifically, there's a reduction in the glucose metabolism. Our cells are less able to deal with the sugar load. There's a reduction in the amino acid metabolism, and we have an increase in insulin resistance. What does that mean? Insulin is produced from the pancreas, and when we eat a meal, we ultimately need insulin to help us drive that sugar into the cell. So as we get older, our insulin receptors become a little less efficient, and so we're not able to do what we need to do in terms of metabolizing that glucose. So we have increased insulin resistance. We have increased fatty acid beta oxidation, and we have increase in ketone body metabolism. All of these things at the end of the day, no bueno. It's not good for our metabolism, and they make it more difficult for us to deal with the sugar and the fat. What's also happening in the belly, as estrogen declines, we actually start to deposit more fat viscerally. So our visceral fat goes up. What is visceral fat? So there's the superficial fat that you can grab that's really not your unhealthy fat, believe it or not. I mean, it's not healthy, but it's not as unhealthy as what the visceral fat is. Visceral fat is the fat that actually surrounds our organs. That's the no bueno fat. Visceral fat is harder fat. It is a more dangerous fat. And that is really what just drives the insulin resistance and the issues that we have with maintaining our blood sugar. So what's the data around this visceral fat and exactly what's happening? In several studies, one in particular, the SWAN study, is the study of women's health across the nation. They looked at the increase in visceral fat in women through this menopause transition. And what they found is that there was an increase in visceral fat of 8.2%. 8.2%, that is not an insignificant amount. And that the 2 years prior to the menopause transition and the 2 years after, there was actually a 5.8% increase 2 years before and after the final menstrual period. That's one study. In that study, they looked at over 500 women. And another study looked at 102 premenopausal women. They were followed for 5 years. And what they found is that each woman saw a significant increase in visceral fat compared to their premenopause baseline. So premenopause baseline, they may have had a visceral fat score of anywhere from 5 to 8%. That increased to 15 to 20%. So there's actually some physiologic changes that are happening. Another thing that changes is our nutritional requirements, right? So as we are entering puberty, there's a specific nutritional requirement that we need. As we are reproductive, there are nutritional requirements. But now in this perimenopause and menopausal period, there are also some very different nutritional requirements, which I'm going to go through right now. We see those changes because literally our basal metabolic rate changes, our metabolism decreases, and there's even changes in our gut microbiome. So at the end of the day, you have actually a lower basal metabolic rate. You have decreased activation of your protein synthesis, and you have that increased visceral adiposity that I spoke about, but you actually have increased need for protein. So your protein requirement now is around 1.2 grams per kilogram of body weight. Your basal metabolic rate actually, that's significant because that's going to decrease 200 to 300 kilocalories per day. So think about that. If you're eating the same amount of food, but your basal metabolic rate has gone down by about 300 calories, the math don't be mathin'. And this is why you're going to see some of those changes. We also have changes in our lipid metabolism. So many women have come in and they have been frustrated because they're like, what is going on with my cholesterol? Well, your LDL levels are going to increase. Your triglycerides will increase, and your apolipoprotein will also increase. So what that means is that now you have an increased need for what we call polyunsaturated fatty acids. We need more like omega-3 type fatty acids to kind of mitigate some of those other changes that we're seeing in our lipids. And then we also are going to see that we need a decrease in saturated fatty acids. What are saturated? Saturated fats. Those are the fats that basically get hard when they get colder. These are the fats that are going to most negatively affect your lipids. And so we need less of the fats that are coming from meat, processed foods. We need good fat, omega-3s, omega-6s, and omega-9s. Our B vitamin requirements, this is important. Our B vitamin requirements change as well. Why does that happen? It's happening because of the change in the microbiome diversity of the gut. So as we get older, our gut tends to look more like men. We have less diversity in the gut, and that is impacting the way we're able to absorb and to incorporate certain vitamins, B vitamins specifically. We also have a decrease in hydrochloric acid, an intrinsic factor in the gut. There's certain medications that might interact with your B vitamins, and of course, alcohol, really, I hate to be the bearer of bad news, but there's really not a lot of good that comes from alcohol, especially as it pertains to the gut. And so it's really important for B vitamins to be included in your diet, whether it's through supplementation or through just finding those B vitamins in your food, because those B vitamins are important for energy production, for the metabolic pathways, and for fats and proteins to be processed. B vitamins also play a significant role with the nervous system. Another finding that I hear from patients a lot is that I just don't digest food the same way. I can't eat the same things. I can't eat the same things. I used to be able to eat all kind of things spicy, and now it's just not fun anymore. So it's kind of frustrating. My gut has definitely changed, and so many women come in and have this complaint. And this may be, in fact, related to a B vitamin deficiency. B vitamins are critical in the production of energy, and B vitamins can get kind of tricky. There's 8 different B vitamins, and they all play a different role in how we metabolize and how we are able to convert and have more energy. In one study, in a lecture, they talked about a company, Zoe, that did a really nice study looking at about 1,000 women. 400 of them were premenopausal, 200 of them were perimenopausal, and 400 of them were postmenopausal. And what they did is they looked at these women's diets. They had them wearing continuous glucose monitors. They looked at their gut flora, blood work. And at the end of the day, what they found was that women who had better diets ultimately had better glucose metabolism. So that's not really rocket science data. I think in integrative and functional medicine, we understand that what you eat actually matters. So hopefully conventional medicine is coming along and realizing that, hey, maybe we can talk about, your diet and how all of these things are coming together. But also, again, going back to the microbiome, in another study that was described, these researchers actually supplemented the microbiome with certain lactobacilli. And we know that as we age, the lactobacilli content goes down. That lactobacilli that's in the gut is actually the same lactobacilli that's in the vagina. So that's affecting some of those symptoms that you may feel, which are dryness and irritation, increased risk for maybe certain yeast infections. This is pretty groundbreaking because we know that just by supplementing the gut microbiome, we can actually decrease the vasomotor symptoms, and we can decrease some of those, what we call genital urinary symptoms of menopause as well. So what's the take home message? At the end of the day, smoking, alcohol consumption, processed sugars, ultra processed foods, and anything that's not nutrient-based food, those are going to worsen your vasomotor and menopausal symptoms. And what's going to give you fewer symptoms? A plant-based diet, lower fat, fiber, fruits and vegetables, foods with what we call a low glycemic index. And that glycemic index really is a measure of how quickly does it make your blood sugar go up? Is it a rapid rise and then a fall, or is it a slow, gradual? So foods with a lower glycemic index are going to help with some of your symptoms. And the B vitamins, I cannot overstate the B vitamins. Magnesium, definitely 400 to 800 milligrams per day, and vitamin E, 400 IUs daily. These are some foods and behaviors that you can actually change. A study that was described that really goes along with what we already know about eating better food and how that's going to make us feel. But they did a 12-week intervention study, and they're looking at the vasomotor symptoms of menopause. And what they did is they put everyone on a vegan diet, a lower fat diet, and they all had them eat half a cup of soybeans daily. So in this study, they not only saw that there were physical changes, but they also saw changes in sexual health. So when we're even talking about mood disorders and headache, this can actually be affected by your diet. So saturated fatty acid intake, sugar sweetened beverages, and ultra processed meats are all associated with more depressive symptoms headaches, and poor concentration. This was another study that was shared. And in that same study, they noted that there was a reduction in depressive symptoms and headaches with higher omega-3 fatty acids, with vitamin E, 400 IUs a day, increasing those isoflavones, aerobic exercise, yoga, and vitamin B6. These all help the women have less depressive symptoms and headaches. And let's talk about sleep. In that same study, they looked at sleep duration and or the quality of sleep. And they noted that alcohol, processed foods, and foods with a high glycemic index all led to decreased sleep or poor quality sleep. In terms of improved sleep duration and quality, phytoestrogens, magnesium, vitamin D3, melatonin, fiber, low glycemic index foods, more protein, which includes that tryptophan, which actually helps us with sleep, and omega-3 fatty acids. This actually, they found that it reduced anxiety and stress, but it didn't change how well you slept. What I thought was one of the most interesting things, because this really took me back to my integrative medicine days and this Mediterranean diet and the impact of it. So this is not news, but thank God again that conventional medicine is catching up. They're studying how the Mediterranean diet affects women in postmenopause. So in this study, they looked at the potential benefits and they saw that the Mediterranean diet actually reduced muscle catabolism in postmenopausal women, meaning it helped to reduce the breakdown of muscle in postmenopausal women. It improved bone mass. It was protective against coronary artery calcification, and it slowed the progression of carotid artery thickness. The Mediterranean diet was also helpful in reducing body weight. So a very low calorie, 1,200 calorie per day Mediterranean diet will be helpful, and cardiovascular exercise. These both have been shown in data to help with weight reduction. So in conclusion, from the metabolic standpoint, weight loss alone is not going to just address the nutritional and physiologic needs of the body. We have to increase certain nutrients, specifically things such as your B vitamins, all of them. There's a lot of evidence that is supporting that food and nutrients and exercise-based changes actually make a difference. Again, I'm just so happy that conventional medicine is finally seeing what integrative and functional medicine has known for years. So I've gone over a lot of those metabolic changes and some of those lifestyle changes that you can incorporate to mitigate some of the symptoms. Now I'm going to talk about some of the data they were going over around obesity and specifically around GLP-1s. So the first thing you should know is that the scientific community does not necessarily refer to them as GLP-1s anymore. They are called nutrient-stimulated hormones. And these are hormones that are basically released from the gut and have everything to do with how we ultimately metabolize. So what you're mostly familiar with are the Ozempics and the Mounjaros, or otherwise known as semaglutide and the tirzepatide. But there are other quote unquote niches that you might want to be aware of. There are also GIP agonists, there's amylin agonists, there's PYY agonists, and glucagon agonists. So Ozempic and all of this has really become very popular in social media, but these have been around for a long time. One of the first drugs that we dealt with was called Victoza. And that drug is basically similar to the semaglutide, but it was injected daily as opposed to weekly. So they made a small chemical modification to this drug, and that made it more likely for patients to be compliant. They started using it every week as opposed to every day. And this is where we're also starting to see an increase in weight loss. So what was really a shift for me is the lecturer really spoke about obesity as the issue and how we look at obesity like it's almost like a character flaw. Like, you know, if you just would eat a few less fries and if you would just do all these things differently, then, you know, you could lose weight. But when you are battling against insulin resistance and some of the other genetic factors that are really playing a role, and understanding that obesity is a disease, it is not a character flaw. And so a lot of these drugs, they're designed for diabetics, but at the end of the day, they treat a lot of the issues that people that are obese have. And what is the definition of obesity? So BMI over 30 is considered obese. A BMI over 25 is considered overweight. And a BMI less than 18 is considered underweight. So you're really trying to get your BMI technically in between, somewhere 18, 20 to 25-ish. But understand that your BMI also is going to be impacted by how much muscle and your bone density and all of these things. So it's really not what we should be measuring anymore. And this was another point that she made in the lecture, is that instead of measuring BMI, there's a new measurement out. It's called the Roundness Index. Yeah. In the Journal of the American Medical Association, they came out with an article in June of this year, Body Roundness Index and All-Cause Mortality Amongst U.S. Adults. So what this study did is look at a cohort of almost 33,000 people, and they looked at individuals from 1999 to 2018. And what they discovered was that your body roundness index, your BRI, not your BMI, was associated with all-cause mortality. And what that looked like was the higher your body roundness index correlated with all-cause mortality. And what is that roundness index? It's that visceral fat. It's that pear shape. So yes, your BMI is important, but these days we're looking at BRI and looking not only at just it as a number, but understanding that at the end of the day, the more fat you have around your waist, the more round you are. Yeah, no bueno. So what do these GLPs actually do? GLP activation is important overall to our human health. What GLP activation does is increase our insulin sensitivity. It decreases the hepatic glucose production. It increases the ability for us to break down fat, and it increases glucagon synthesis and glucose oxidation, which basically is going to help with muscle production. So GLP actually has a function in the body. It's also going to decrease our blood pressure, increase our heart rate, and increase our myocardial activity. And all of these GLP-1s, GLP-1R agonists, they're going to decrease gastric emptying and increase acid secretion. So when people take these drugs, they actually feel more nauseous. They have more GERD oftentimes, and they might even get constipated. And that has to do with the decrease in mobility of the gut. But where they especially work is in the brain. They really do turn down what we call the food noise. They decrease appetite, they increase satiety, and increase energy expenditure. When we were younger, it was all about getting in that dress. It was about being cute. I mean, it's still about being cute. But now it's about being healthy ladies, right? It's about understanding that the habits that we created as we were younger may not be serving us as well. What are those habits? The alcohol, the eating, and not paying attention. It really involves being much more intentional about everything you put in your mouth. And again, this is not meant to, be like, hey, you can't eat and you can't do the things, but start to understand that it's not about the aesthetic. It's about your health, and it's about longevity, and it's about the quality of life. And the better you can really start to make some of these changes, the higher quality of life you're going to have. I'm looking at my parents' age, and I'm looking at some of the complications that my dad has dealt with his health in terms of diabetes and hypertension and obesity, and what that looks like later in life. And I don't have, the greatest genetics. Everyone in my family is pretty much hypertensive, diabetic, got some heart disease. Both my parents had heart attacks. So I'm like, yeah, I want to look cute. But guess what? I'm trying to have the best quality of life. I am proposing that it's time to be intentional about what to put in your mouth And what your body looks like is not about getting in that cute dress, in that skirt. It's about what's the roundness index and what are we going to do to increase our odds of having the best quality of life as we age. So I've talked about the GLP-1s, we've talked about metabolism, and I want to explain now what the role of estrogen really plays in all of this. So how can hormone therapy, specifically estrogen, help? So what we know is that estrogen improves insulin sensitivity. That's why as we get older and our estrogen levels decline, our insulin sensitivity goes down. Estrogen is going to help the cells respond better to insulin. What else does estrogen do? It can actually lead to a more favorable fat distribution of body fat. So remember I talked about that visceral fat? It will actually help in the distribution of reducing visceral fat, which is more correlated with insulin resistance. Estrogen also has anti-inflammatory properties. A lot of these things that we're seeing is a result of inflammation. Inflammation at the end of the day is the devil. Inflammation is the root cause of just about all disease. And we know that estrogen has anti-inflammatory properties that can reduce chronic inflammation, and that is also associated with insulin resistance. Estrogen positively affects lipid metabolism. Estrogen directly influences glucose metabolism in the liver and in muscle cells. So it actually enhances our body's ability to utilize glucose effectively. Now, I'm saying all of these things, not because I'm an estrogen pusher, which, if you caught me one, I would take it. But I'm saying all these things for you to understand how estrogen has showed up in your body all these years. And what we see is that women, as we go through this transition, as we get into this postmenopausal state, our blood work starts to look more like men. Our lipids get worse. Our bones get less. Our muscles, our cognition, all of this is directly impacted by our estrogen levels. And so the goal really is to slow that process down so it's not perhaps as abrupt. And then at the end of the day, you can decide to take estrogen. You can figure out later on, like if you want to stop it. So you have to be mindful that your estrogen works while it's working. But when it's not there, it's not, those improvements aren't going to continue. So a common question I get from patients is, well, how long do I need to be on this estrogen? And I say, well, how long do you want to have good bone health? And how long would you like to think more clearly? And how long would you not like to have hot flashes? And how long do you want to have the benefits of the lip protection? I'm not advocating for everyone to stay on estrogen forever, but understand that that's an individual conversation that you can have with your provider. There's no reason why you cannot be on estrogen really for the rest of your life. Now, you are not a good candidate to start estrogen when you're much later in life, or we believe at least 10 years outside of postmenopause, because now we're introducing something that can cause more untoward effects than beneficial effects. We actually do see some negative consequences. This is why starting estrogen in your perimenopause and early postmenopausal years is so important, and not to wait until you are much older, because that period is when you're really going to be seeing so many of those changes. So the findings in one of the abstracts, which was that hormone therapy at the end of the day reduced insulin resistance in healthy postmenopausal women. I want to summarize these GLPs and leave you with what actually surprised me in terms of some of the recommendations around continued use. These drugs are being used more and more, even during this perimenopausal period. There's not a lot of data around that, but we know exactly what they do and how they function. And we understand how estrogen affects it all. So thinking about estrogen, thinking about the GLPs, these are all tools that ultimately could be beneficial. Everyone is not necessarily a candidate for estrogen, and I'm definitely not suggesting that everyone need to be on a GLP-1 agonist. But what I am saying is understanding that obesity is a disease and that these drugs really do treat the root cause of a lot of these issues that we see during menopause and in patients that are obese. So what was also surprising, though, was the question of how long do people stay on these drugs? Now, that has always been a question for me because I have patients that are like, well, how long do I stay on this drug? And I'm like, I don't know. How long do you want your lipids to be good? There is no data to support how long you could stay on these drugs. And the data that we do have is that these drugs are going to improve your lipid profile. You will lose weight. They are now seeing that this drug is affecting risk for Alzheimer's. We know that it's protecting the brain against stroke and decreased risk of heart attacks. Your cardiovascular risks are decreased. So if you're taking this medication for obesity or for diabetes, I say keep it going because it is having a positive impact on your health. I can't speak to all the rest of y'all who are just trying to get your hands on it. I understand, but you definitely need to have those conversations with your provider and understand that it's just not a one and done. You don't just take the medication and stop, because we do know that people who take it and stop generally gain the weight back. We also know that people that stay on the medication, the longer they stay on the medication, the more likely they're going to be able to keep that weight off. But it is not one of those drugs that you want to be yo-yo dieting on. And the other thing you got to know is that when you're losing weight on these medications, think about this, you're actually losing fat and you're losing muscle. If you gain weight back, you are gaining back fat. You are literally changing your body composition and the balance between your lean body mass and the amount of fat that you have. So the more weight you lose without keeping up with that muscle mass, the more detrimental that's going to be to your health. A really important lesson to know. But the take home from the conference was that generally speaking, you should stay on these medications if you're on these medications for a longer period of time, longer than just the time period that you just want to lose that weight or control that diabetes. That was an interesting point. And the next thing we're going to get into is the brain health. So one of the interesting points that came out of some of the lectures was this relationship between anxiety and hot flashes. According to the data on this SWAN study, the study of women's health across the nation, anxiety is going to peak in perimenopause and in early post-menopause. That's when women are the most susceptible to this. But when the findings were controlled for hot flashes and night sweats, anxiety pretty much went away. And it meant that the anxiety seemed to be related to the hot flashes. So we don't know what came first, the chicken or the egg, but it's beginning to look more like the hot flashes themselves are what's causing the anxiety. Another thing about the hot flashes and around brain health, Dr. Pauline Mackey presented some data around what hot flashes actually do to the brain. And this was really startling to me because I take hormone therapy. I still get hot flashes. I don't get hot flashes during the day. I get night sweats, and I only sweat from like my neck up. And so the pillow will be wet. I have to flip it over in the middle of the night. It's not a big deal to me. I didn't think it was a big deal. But actually night sweats, hot flashes, each time you're having those, they're noticing that there are these small ischemic, like stroke-like lesions in your brain. Some data suggested that it was the estrogen that was improving the brain. But what we actually note is that the hot flashes themselves are what's causing the brain changes. So there's a lot of confusion around estrogen now and the risk of developing Alzheimer's and dementia and whether or not estrogen is protective in that regard. What I want to clarify here is that, number one, there's no absolute data that confirms that estrogen is going to decrease your dementia risk. But what we know is that estrogen decreases the hot flashes, which affect the ischemic lesions in the brain, which in turn increase your risk. Anything that ultimately is going to stop the hot flashes is actually going to improve your brain health. It is not necessarily the estrogen. Now, estrogen still has all of those benefits that I mentioned. And at the end of the day, it's anti-inflammatory. So we know estrogen plays a role somewhere, but there's no data that specifically can correlate estrogen with decreased risk of Alzheimer's. So Dr. Mackey got us straight on that. The other thing that I thought was interesting was the data around depression. And as we know, this perimenopausal, menopausal time, there's going to be a higher incidence of depression. The time between the late menopause transition and the early menopause, that window is when we're most vulnerable for depression. So it's the 2 years before the last menstrual period and the 2 years after. That is when women are most likely to be affected by depression. Now, depression can be impacted by so many other factors, but there are women that have never had a history of depression and are experiencing this during their perimenopausal period. The biggest risk factors for having depression is having previous episodes of depression. When a woman has not had a history of depression, the risk of her having depression during this period is actually much lower. So in terms of depression, some of the takeaways you want to get here are, number one, if you've had a history of depression in the past, you have an increased likelihood of having some depressive symptoms during this perimenopausal transition. Estrogen can be helpful, but with severe depression, at the end of the day, the recommendation is that you are going to benefit from an SNRI or an SSRI or whatever type of antidepressant agent. But that said, the Mediterranean diet, once again, and exercise, yes, it just like it reduces your insulin resistance and helps you in all these other ways, it also is going to decrease your risk for depression. So it circles back to the point that your food is your medicine. What you put in your mouth matters, and how you move your body matters. Exercise and diet are some of the best things that you can do for your brain health. If you have not had a depressive episode prior to this perimenopause, then your odds of having depression during this transition period is actually lower. But understand that that is a very common symptom. It's not unlikely that you will feel some sense of anxiety and or depression during this transitional period, but know that there are some lifestyle changes, there are medications, and that estrogen, again, can have an impact on how you experience these things. I'm going to move on to the last point, which is on bone and muscle health. So, bone health isn't sexy, but it's important. And the statistics were pretty alarming. I've heard these statistics, but hearing them again, and I think it's because I'm older now, and it's like, oh, those numbers are not good. So let me read you some statistics. If you were 65 years old in 2021, then you are likely to live another 20 years. So you're at least likely to get to 85. Why does that matter? Physical frailty is the number one cause of admission for women into long-term care facilities. Hip fractures, 20% of women will die in the first 12 months of a hip fracture. All of this is relevant because by age 50, 16.5% of American women will have osteoporosis. White women over the age of 50 have a risk of an osteoporotic 40% risk. So do that math. Definitely, if you have a family history, you're white, and you have a smaller frame, your risk for osteoporosis just goes up. That is an indication alone for estrogen. Estrogen will protect your bones, and that there's no controversy about that. Your risk of having major complications from osteoporosis far exceeds any risk that you might perceive from taking estrogen in terms of breast cancer. Now, let's talk about sarcopenia. Sarcopenia is muscle loss. So osteopenia and osteoporosis, bone loss. Sarcopenia, muscle loss. Our muscles are going to peak at age 30. Until age 75, every decade, we lose about 3 to 8% of a muscle mass. And then after 75, we're losing about 1%. Women who have sarcopenia have 13 times risk of having osteoporosis. This is why your muscles matter. This is why you need to eat your protein, take your creatine, do your weight bearing exercises, and consider estrogen. Bone loss starts in this perimenopausal period, and you are going to lose 10 to 12% of your bone mass during this perimenopausal period. Estrogen is not only going to mitigate the bone loss, but it actually is going to increase bone density by up to 2 to 5%. There's so many benefits in terms of how estrogen can prevent morbidity and mortality in women. And when I have this conversation with patients around estrogen, I talk about quality of life. Maybe on the best day, you might decrease your risk for breast cancer by 1%, 2%, whatever that is. But your quality of life is significantly impacted. And all I'm saying is, if you're suffering, that's just not necessary. Estrogen has literally been demonized as a drug, and it is much more difficult to turn people's minds around, to undo something than it is to give them information. The WHI study just set the foundation for really, I think it was one of the worst things that could have happened to women's health, but I digress. Now, let's do the math. By age 50, 16.5% of women are going to have osteoporosis. White women over age 50, your risk for osteoporotic fracture in your lifetime is 40%. If you have a hip fracture, 1 out of 5 women are going to die in the first 12 months. This is why you got to take care of yourself during this period, because what you do during this transition is critical for the rest of your life. And so there's some decisions you can make. There's some changes you can make that are going to literally change the trajectory of your health. And I'm not being dramatic. Maybe I am, but yeah, I'm going over one last thing here. And this is a syndrome that was described most recently in one of the journals, Climacteric, and it came out this year. It's a review article, and they describe what is called the musculoskeletal syndrome of menopause. This is the explanation for the frozen shoulders, for your joint pain, your bone loss. This is the explanation for your muscle loss. This is the explanation for the arthritis. Interestingly enough, joint pain is actually considered one of the top symptoms of perimenopause. And that pain is directly related. Musculoskeletal syndrome of menopause. This is the first time I've heard it described that way. We have genital urinary syndrome of menopause. That's about all the things that are happening down there. But now we got the musculoskeletal syndrome of menopause. What we really have is people paying attention to what's happening to women as they age. That's really what's happening here. These aren't new things that are happening. These have been probably happening, and I'm sure they've gotten worse over time for all the reasons, our diets, our lifestyle. But at the end of the day, these are real syndromes, and they have real consequences for your health. So in this article, they basically describe 5 of those categories, which I went through. The only one I didn't mention was inflammation. So bone loss, muscle loss, arthritis, joint pain, and inflammation. So bone loss, muscle loss, no bueno. Muscle loss is going to contribute to osteoporosis, and you don't want osteoporosis. Why is that also important? A lot of you are losing weight. A lot of you are on these GLPs. Please don't get it twisted. You have to keep your muscle, because if you lose your muscle now, you have really put yourself at a significant risk. If you lose muscle and fat, and then you come to gain that weight back again, you're not gaining muscle back. You're gaining fat. And now you have just influenced your lean body mass to your fat ratio. And that's no bueno. That about summarizes a lot of things. There were a lot of points I didn't even get to make, but I have gone on long enough. And I think we're just going to have a part 2. Thank you all for listening and watching, and I hope that you learned. That was a lot of information. I tried to really summarize this in a way so that you could understand how this transition is affecting you on a biological level. It's not all in your head. You are not going crazy. And yes, you are getting that belly fat for no good reason. I mean, there's a good reason, but there's no good reason. So one last thing, one of the next episodes we're going to be delving into is what I call women on the glow. So women on the glow are women who have taken this menopause, perimenopause bull by the horns and just doing the damn thing. Our first woman on the glow is going to be Miss Jill Oser. I cannot wait to introduce you all to her. She's got a story, girl. Lord, y'all. I can't wait. I cannot wait to interview her. We're going to have so much fun. So stay tuned, stay brilliant, stay beautiful. But most of all, you know what to do, ladies. Keep it juicy.